immunology that can help people in the transplant lab, immunology lab, or fellows in transplant nephrology or transplant immunology. It's really very useful course, I believe, and we have excellent faculty joining us. Before I introduce our first speaker today, I would like to tell you about the CME certificates. Our course will be accredited by ABHI, the American Board of Histocompatibility and Immunogenetics. You will receive CME within 10 days of today. Within 10 days, you will receive your CME certificate. That is ABHI certified. And I would like to ask everyone, please, to keep your microphones off, mute your phone. If you are to ask a question at the end of the talk, you are most welcome to have your phone on. Our first talk is HLA sensitization and antibody detection. It gives me great pleasure to introduce Dr. Mohamed Awaji. Dr. Awaji is a clinical scientist at the Histocompatibility and Immunogenetics Laboratory at King Fahd Specialist Hospital in Dammam. He is certified by the ABHI and he is an active ASHI inspector. Dr. Awaji has been in the field for more than 17 years and he has lots of publications in this field. Please, Dr. Awaji, thank you.
Thank you very much, Dr. Ali, for the introduction and also for inviting me to speak in this forum. I'm turning on the camera just to say hi to everyone before I will turn it off. Can everyone hear me okay?
Yes.
Thank you very much. All right, our talk for today is HLA sensitization and antibody detection. In this talk, I will cover HLA antibodies in transplantation, and this will include preformed HLA antibodies, post-transplantation antibodies, and cytotoxic antibodies. The second part of my talk will cover antibody detection methodology, and this includes cell-based assays and solid-based assays. HLA is the major histocompatibility complex in humans. HLA is a cluster of genes that is located in the short arm of chromosome 6. And they are all closely linked and classified into class 1, class 2, and class 3. For transplantation, we're only interested in what we call classical HLA molecules. And the genes for these molecules are distributed between MHC class 1 and MHC class 2. And this includes HLA A, B, and C from class 1, HLA DR, DQ, and DP from class 2. MHC function include or mainly is the antigen presentation to T-cell receptor during adaptive immune response, which make MHC molecule as part of the adaptive immune system. And one thing we know about adaptive immune system is specificity of reaction. This specificity is achieved through the fastidious binding capability of T-cell receptor and B-cell receptor. And the specificity of T-cell receptor and B-cell receptor is achieved through somatic gene rearrangement for the hypervariable region for these receptors. On the other hand, MHC is different. It has a promiscuous binding, which means a single HLA molecule can bind to so many different peptide sequences with little discrimination. To increase their power for peptide binding, MHC molecules has adapted to become polygenic, which means that they present in multiple loci, including 3 loci in class 1 and 4 loci in class 2, which makes up to 14 different molecules per person. They are also known to be polymorphic, which means an HLA can be different from one individual to another individual. This diversity of the HLA system increases the repertoire for peptide binding, which help individual to fight different pathogens. But for the society as well, the diversity of HLA prevent immune evasion of pathogens. If someone is susceptible, the other person can be resistant to certain pathogens. So this complexity of the HLA system has made transplantation a more challenging process. Mismatches found on the graft of the donor, taken from a donor and given to the recipient, can be recognized by the immune system of the recipient. And this can elicit an immune response, resulting in the development of anti-HLA antibody. And that is the subject of our talk today. A successful transplantation is an effort of multidisciplinary team, including physician, surgeon, HLA lab, and many other disciplines. The aim of the team is to maximize the benefit of the graft by minimize the chances for graft loss. Graft rejection is a risk that is associated with transplantation. And graft rejection is classified based on the duration of its occurrence into hyperacute rejection, also known as immediate rejection, that can happen within minutes or hours within the transplantation. And this is mainly due to preformed antibodies targeting the graft mismatch found on the graft. In addition, acute and chronic rejection happen in much longer period, and that can involve antibodies as well as cellular components. The role of the HLA laboratory is to prevent the immediate graft loss and also to minimize the risk for the development of other kinds of graft rejection. In 1969, Patel and Terzaki published a very distinguished paper. This paper has set the ground for our current understanding for humoral risk stratification. They illustrated in this paper that about 95% of all recipients who had an immediate rejection had a some form of preformed HLA antibodies. And 80% of them had a positive cytotoxicity crossmatch. And since then, a positive cytotoxicity crossmatch has been considered a contraindication for transplantation. So they deduced that the preformed antibody are responsible for immediate graft failure. So how these preformed antibody develop? They develop through allorecognition of foreign HLA that can circulate or recognized by the immune system of the individual potential recipient that is getting transplanted. One of the main mechanisms for this is through pregnancy. Women, when they get pregnant, they get exposed to the mismatches carried by their children. And these mismatches usually always inherited through their father. Which makes it difficult for a female recipient to find a donor within their core family. And also it exaggerates the number of women on the waiting list because it makes it the ratio of women to men higher for the people on the waiting list due to their increased sensitization. Additionally, blood transfusion also can lead to allorecognition. We can find this in those patients who receive frequent and multiple blood or blood components such as platelets or multiple transfusion. Additionally, in compliance with immunosuppression or tapering immunosuppression, in response for infection, for example, in transplantation can lead to allorecognition of donor HLA typing mismatches and result in the development of HLA antibodies. Other mechanisms also include molecular mimicry during infection or vaccination, and also certain autoimmune diseases. Although the evidence for these two is not as strong as the previous three. In addition to preformed antibody, post-transplantation HLA antibody has also shown association to an inferior graft survival. We can appreciate this by looking at this graph that patient with DSA has lower graft survival and also lower patient survival compared to patients with no donor-specific antibody post-transplantation. So we know by now that all antibodies are bad for transplantation, but are all of these antibodies that harmful? For antibody to be harmful for transplantation, first it needs to be a donor-specific antibody. We usually in the field of HLA, we refer to them as DSAs. If you look at this example, we can see that the recipient antibody profile carries multiple antibodies, including antibodies to A2, A68, B8, and DR17. If we look at donor HLA typing that will be carried on the graft, patient does not have any corresponding antigen to those antibodies, which means this patient has no donor-specific antibody. In this other example, we see that the donor HLA typing contain A2 and DR17, two antigens that the patient has antibody against, which make antibody A2 and DR17 donor-specific antibodies. So in addition to being donor-specific antibodies, antibody has to elicit cytotoxicity or tissue injury. One of the prominent mechanisms by which antibody can elicit this tissue injury is through the activation of complement cascade. In this figure, we can see that C1 complex composed of C1q and C1r cross-linked with the antibodies attached to the HLA antigen on the surface of the graft. The activation of C1 complex starts a cleavage of consequent complement component in a cascade fashion. Most of these complement components usually get cleared by the system. Some of them tend to stick around, like C4D, that usually stay around for longer time. C4D can be used and has been used for decades now for confirmation of antibody-mediated graft injury. In this figure, we can appreciate that how cytotoxicity antibody that include that is being a donor-specific antibody as well as being a complement-fixing antibody infer an deteriorating effect on the graft survival compared to those with no donor-specific antibodies or donor-specific antibodies that cannot fix complement. So what type of antibody that can fix complement? When we're talking about graft, we're talking about antibody that can be present in the circulation. Immunoglobulin have 5 isotypes, and the antibodies isotype of interest is IgM and IgG. IgM is usually secreted during the primary response and usually in a transient fashion. IgG is secreted during the secondary immune response and tend to stick around for longer time. IgM can fix complement, but because it's transient, it has little relevance to transplantation compared to IgG. IgG has subclasses. These include IgG1, 2, 3, and 4. But only IgG1 and IgG3 can fix complement. So if we have antibody that is IgG2 and IgG4, they are less relevant, less cytotoxic to transplantation, and can be a little bit amenable. So to sum up so far, we know that HLA antibodies are deleterious to transplantation, but not all antibodies are harmful. harmful antibody need to be donor-specific antibody, and the harmful antibody need to be of cytotoxic nature. The next part of my presentation will discuss antibody detection methodology, and these include cell-based assay and solid phase assays. Cell-based assay uses a technique that has been used for decades. Actually, complement-dependent cytotoxicity has been there probably since the 50s or 60s. And it is one of the oldest techniques we are using in the HLA lab. It's not commonly used nowadays with advancement in solid phase assay, but it has certain clinical relevance that you cannot get with a solid phase assay. Complement-dependent cytotoxicity is also referred to as lymphocyte cytotoxicity assay, and this is because it has a panel that contains cells obtained from different individuals, usually at random, to account for the antigen occurrence within a population. So antigen like A2 is very common, and antigen like B78 is not that common. So to account for the frequency of this antigen, we usually collect these cell in the panel in usually a random fashion. So using this tray, we incubate a serum from the potential recipient with these cells, and then after a certain time we add complement. And as we know from what we discussed in complement, when there is antigen-antibody interaction, complement can elicit cytotoxic effect on the target cell. So if the patient has HLA antibodies, these antibodies will bind to their correspondent antigen on the cell or cells contained on this panel, and the complement will cause these cells to be dead. And then using a vital stain, we can stain for viability or death of these cells. Dead cell will be positive, considered positive, and viable cell will be considered negative. If a patient has few antibodies, usually with this technique, we can identify those antibodies. But usually with patients that are highly sensitized, it is difficult to try to figure out the specificities contained within the serum of this patient. So we often resort to some another kind of approach. We call it percent PRA. And percent PRA means panel reactive antibody, and it means the percentage of cells within the panel reacted to the serum of the patient. And in other words, it means the chances that this patient will turn positive in a cytotoxic cross-match when tested in random with a random donor within the population. A2, for example, is of high frequency within the population, within our population, and within many other populations as well. A2 present in 19 cells within this panel. So if the patient has only A2 for an antibody in their sera, they will get around 32% PRA. Additional antibody to A2 will increase the PRA, which will decrease the chances of that recipient of finding a compatible donor. But not always the increase of antibody is associated with increase of PRA. If the antibody is not of high frequency, such as in this example, which we see that this recipient has 4 antibodies, but they're not of high frequency as we've seen in the first example. Those antibodies made only 7 out of 60 cells to become positive, which gives only 4% PRA. So as we discussed, complement-dependent cytotoxicity has a clinical relevance because it can detect those antibody that can fix complement and induce cell death, mimicking that what will happen real time to the graft. But it has many problems which led to being an outdated technique that is not used widely anymore. And these difficulties include difficulty to maintain, and because usually we need viable cell to start with for our assay, and then it also has lower sensitivity compared to solid phase assay, as we will discuss in the next section. Many of the uncommon antigen are not represented in these panels, and the interpretation of this assay is usually subjective because one person can interpret it to be positive while other person can interpret it to be negative. And this is usually due to low viability to start with in the assay. So for this reason, solid phase assay has been started to be widely used. Solid phase assay means any assay that is not using viable cells, and this include techniques such as ELISA, flow PRA, and suspensions array commonly used or commonly called Luminix. For flow cytometry-based antibody detection and Luminix-based antibody detection, they use very similar approach. So when I will discuss them, I will discuss Luminix as an example for both of them. I'll start by discussing ELISA. And ELISA is one of the most known serological techniques and known as enzyme-linked immunosorbent assay. And it is in an enzyme-based assay. The HLA antigen is usually tagged to the well through a tagging antibody. Then serum of the patient is incubated on with these antigens. If a specific antibody is found as corresponding antigen on that well, it will bind to it, and then a secondary antibody containing a tag will be added, and then through an enzymatic reaction, this assay will produce a color that can be detected with a spectrophotometer. ELISA is widely used now for antibody screening, but is not very useful to do for antibody characterization and specificity, as it needs many wells to do that. So multiplexing of antigens within one testing tube was the way to go for antibody detection. That's why new techniques such as flow cytometry and Luminix were introduced. This technique uses microsphere bound antigens, and this microsphere usually have different fluorescence index, and because of their different fluorescence index, the Luminix machine or the flow cytometry can recognize each one of these beads or microspheres. So the techniques include a microsphere that has a specific fluorescence index tethered to an antigen, and then the serum of the patient is added to that mixture of beads. And if there is antibody present in the serum of the patient, this antibody will find their correspondent antigen and will bind to it. And then after washing, we add a secondary antibody. It's usually an anti-IgG antibody that is tagged to another fluorescent material that can be read also by the flow cytometry or the Luminix in this case. The amount of the fluorescent produced by the secondary antibody is usually correspondent to the amount of antibody reacted to the antigen, which is another way correspondent to the amount of the antibody present on the patient's serum. And this is reflected as a number. We usually refer to it as mean fluorescent intensity, or MFI. This provides a semi-quantitative method that can be used to develop assay that was not possible before, known as virtual cross-match. I will talk about it after this slide. So the Luminix assay has 3 levels of assays, and this include the screening assay, phenotype assay, and single antigen assay. The screening assay microspheres composed of antigen coating the microsphere obtained from 3 to 5 individuals, and means to find out whether this patient has antibodies or not. This phenotype assay is in a way similar to that we seen in panel reactive antibody. The microsphere in this assay is coated with antigen obtained from 1 individual. The ultimate assay for Luminix is called single antigen, and in this assay, each microsphere is coated with multiple copies of the same antigen. And this antigen is usually produced through recombination, and this can be problematic, as we can see in next few slides. So I told you that single antigen is a powerful tool that can allow us to do a virtual cross-match. Before, when a patient has very few antibodies, we can use that to do virtual cross-match by comparing the antibody profile of that patient to the antigen carried by the potential donor.
Dr. Awaji, we have Dr. Awaji, تسمح لي.
Yes.
We have 3 minutes.
طيب, I'll try to.
Please,
I'll try to wrap up, inshallah. So by comparing the antibody profile for highly sensitized patients, we can find their corresponding antigen on the donor type. And by comparing the MFI of this antigen, we can define this as being either strong, moderate, or amenable donor-specific antibodies. And we can allow us to either refrain from this transplantation or go ahead with the transplantation. So single antigen is not really perfect. We, as I said, these antigen are produced through recombination, and this can be problematic. And for the sake of time, we'll just skip this slide. And here I'll also mention that there is some modification can be used to the single antigen, because the secondary antibody is usually an anti-IgG antibody, and it does not recognize whether the antibody is complement fixing or not. This modification allows to look further for the antibody and see if it's of clinical relevance or not. So to sum up this part, we see that solid phase assay has a lot of pros compared to cell-based assay. And the only disadvantage of this is that it does not test for cytotoxicity with the original setting for the test. So in summary, we know that preformed DSA cause hyperacute rejection, and we need to prevent this from happening. We need also to minimize the risk for post-transplant DSA by monitoring post-transplant antibody profile for the patient. We discussed different techniques for antibody detection that include solid phase assay and complement dependent cytotoxicity. With that, I conclude my talk, and I'm ready to take any question or comment. Thank you very much.
Thank you so much, Dr. Awaji. A very informative talk. I really appreciate your time, your effort that you put in this talk. Anyone has a question, please? If you have a question, please speak. If there's no more question, thank you so much, Dr. Awaji.
Thank you very much.
Thank you. I really appreciate your time and your efforts.